did not prevent her. Anyway, by a show of hands, if I make a big stink about this room over here as a study area, who would use it after hours? Show of hands. Hang on just a second. Hold just a second.
Mine is rather the most important hand, you should know that.
We would for sure, because Blair's getting more crap about the library. Raise your hand because you're a kid.
Blair's about to get the whole program out of the library.
So raise your hand high here, Taylor.
If you want them, so the lounge? Yeah, okay. Let's go to raise my hand.
Yeah.
Yeah, I feel like everyone, so it's like, oh gosh, don't look, he's like taking.
You get the fan real. You don't know how to do that.
So, I'll play with you about that space and we're
You
going
want us
to
to get
go.
a petition started?
Huh?
You want us to get a petition started?
President.
President, you're on it.
No, anyway. The other thing is, the people who have the 4 keys to the lab over there, when you get over to the lab, can you use that key and try to open any of the other rooms across the hall, like 102, 105? They don't open any of those other rooms. They only open the outside.
I've tried.
Is that what you tell me?
Yeah, I tried to open the ecology room when I left my charger in there and it didn't work.
Okay, so it only opens the outside as far as you know. Okay. Welcome. Okay, so we're going to talk about these 3 areas right here. When we get over there, I'll take one of the cadavers. Anybody going to eat this right here? Anybody going to eat that? I'll do an ankle. It's the ligaments on the ankle are pretty interesting. So, is it on? Okay. This you've already had. However, I do want to tell you that the parts of long bones that are relevant, you'll hear it expressed, are the shaft is called the diaphysis. And the part where the shaft balloons out, sort of the neck, is called the metaphysis. And in the end of it is called the epiphysis. The growth plate is the epiphyseal plate. It occurs between the epiphysis and the metaphysis. All right, but the shaft is called the diaphysis. Okay. On the leg down here, you do have an interosseous membrane, just like you did in the forearm. There's a gap here at the top of it where we'll see the artery piercing through that gap. There are, as this illustration shows you, quite a few nutrient vessels within the long bones. It's amazing. There's a procedure. When we get over to the lab, I'll give you one. It's called an intraosseous needle. If you can't establish a peripheral vascular access, you go use this needle to stick it into the tibia, the flat part of the tibia up here on the top. An ion needle can go there. And I was always under the impression that if you were to inject a drug there, it would kind of sit in the marrow cavity and leach out over the next few minutes. But actually, if you go to a YouTube video for EZIO, and look at the fluoroscopy, they inject a contrast material into that ion needle, and as soon as it hits the marrow cavity, it is picked up by the popliteal vein and gone. Wow. It's truly impressive. So in delivering epinephrine and other drugs in cardiac arrest, going through an IO needle is, if you can't get a peripheral line, IO is your next choice. The bones of the thigh and the knee, we've already been through all of these. Any questions? None? Good. We'll move on. So next, back up for the slow person.
Well, we were in lab the other day and we were trying to figure out where the tibial plateau was. Like some of us
The
thought
tibial plateau is just the flattened part.
right above the tuberosity, right?
Yeah, it's just the whole flat part on the top,
On the top, okay.
where it comes out, that whole thing is the tibial plateau.
Okay.
In this area right here, you've had all of these, but a couple of items I want to point out. And that is, note that the fibula does not articulate with the femur. The fibula does not articulate with the femur, and it is lateral. You cannot feel it in you. At least the shaft of it, at least the diaphysis of it. Down here in the ankle, the tibia will go to form the medial malleolus. The fibula is the lateral malleolus. And together they form an upside down U. It's called the ankle mortise, M-O-R-T-I-S-E. C-E, mortise, the ankle mortise. Like a mortise and tenons type arrangement in carpentry for those of you who are carpenters. All right. When you're looking at x-rays, you want this, the spacing of this U to be consistent all the way across there. You know, up, across, and back down. It should be about 2 to 3 millimeters on an x-ray. It's very precise. There are 3 compartments of the leg. There's an anterior compartment, and I mentioned this the other day, a lateral compartment and a posterior compartment. The posterior compartment is divided into superficial and deep layers. Each compartment, the fascinating thing about this is that it's easy to remember. The 3 compartments each have a nerve, and they each have their own blood supply. 3 nerves, 3 blood supplies, you know it all. The anterior compartment here contains a few muscles. These are the 3 muscles here. The tibialis anterior arises from the tibia and the interosseous membrane and inserts onto the top of the foot, the dorsum of the foot. By the way, this is the dorsum of the foot you're looking down on. This is the plantar surface. If you take the foot and move it upwards, that's dorsiflexion versus plantar flexion. Inversion versus eversion. Okay? All right, so these 3 muscles. Extensor hallucis longus extends the big toe. Extensor digitorum longus extends the lateral 4 digits. Raises them up. There's a final muscle called the fibularis tertius, or peroneus tertius. Remember, you can substitute that word, peroneal, not perineal, peroneal for fibularis. That is a lateral in that compartment. And you won't see it up in the muscle, up in the leg. You'll see it though on the surface of the foot. I'll show it to you in just a second. The nerve of this area is the deep fibular or deep peroneal. And the blood supply is anterior tibial. Anterior tibial. Here are the muscles right here. You see that the tibia is medial. So these muscles are going to be lateral in the fat part, in the fleshy part of your feet. The tibia is medial. The muscles are over here in this fleshy part. Okay, all 3 muscles are in that fleshy part. Fibulary, except for peroneus tertius, you find that just down here, it comes off of the tendon of the digitorum longus and inserts into the base of the 5th metatarsal. The actions of these muscles are pretty simple. Tibialis anterior is because of where it attaches. You see it has a really strong attachment right there. It's going to dorsiflex and invert. Peroneus tertius is on the other side of the foot. It's going to dorsiflex and evert. The other 2 in the middle just extend the big toe and the digits. While we're on the surface of the foot, I think I'll bring it up later on, but you can see them down here. You have brevis muscles as well. Extensor hallucis brevis extensor digitorum brevis. The really funny thing about the foot is that it's really cute. I mean, how this is put together, it really is. There's not a lot of fat yet, it's not, there's no fat you have to dig through, you know, you take the skin off and there it is. There's everything in. So it's pretty. Now there is a retinaculum, just like there was in the wrist, a flexor and an extensor retinaculum. Appreciate that if you didn't have that retinaculum, you'd lose the mechanical advantage here in the foot. The lateral compartment only contains two muscles, that's peroneus longus and peroneus brevis. The nerve is the superficial peroneal, and the peroneal artery is the artery. These are the lateral compartments. Peroneus longus and brevis are most lateral. The brevis inserts into the base of the fifth metatarsal. The longus tendon goes all the way across the, that's peroneus tertius, that's the brevis, and the peroneus longus goes all the way across to insert on the first metatarsal. Now what these things do, you see that they're posterior to the lateral malleolus. They're posterior to the lateral malleolus. So what they're going to do is they're going to plantar flex and evert. Plantar flex and evert. They evert the foot. Plantar flex and evert. Okay? Kristen, you look like you
When you say evert, are you turning your foot out?
turn your foot out. Yeah, versus invert. Okay? So, for example, the biggest plantar flexor of the foot is the Achilles tendon, right? But if that snapped, you could still plantar flex your foot using the peroneus muscles, although much weaker. You probably have to give up your job as a prima ballerina, but nonetheless, you could still walk. If you look at the lateral compartment here, here's our brevis attaching right there. And then the longus is going to scoot below the plantar surface of the foot, and I'll show you that in another slide. The thing here that you need to be aware of is that freaking attachment there is stronger than the bone. So an avulsion fracture of the fifth metatarsal head is a common occurrence. It's called a Jones fracture. Jones fracture. So like if you're playing basketball or something and you come down on the weakest part of your ankle is when it's plantar flexed. When it's plantar flexed. So if you come down from getting a rebound or something, and your foot rolls like that, you're stretching, understand it, you're stretching the peroneus tendons. You can actually snap the head of that metatarsal off of there during those types of injuries. It's called a Jones fracture. I'll show it to you later on. Posterior compartment, here are the muscles of the posterior compartment. I want to point out this stupid little tendon right here called the plantaris. Tendon of the plantaris. The muscle is tiny, tiny. You'll see it in the back of the knee. The plantaris is located between the gastroc and the soleus. But you see it in any cross-section of the leg, just essentially as the tendon. That's all it mostly is. All right, so over here on this side, you got the tibialis posterior, then you've got the flexors, the long flexors anyway, and superficially, the gastroc and the soleus. Here are the superficial ones here. The gastroc has two heads. These arise from the tibia. They don't cross the knee joint, so they have no flexion at the knee. Their function is at the ankle. You've got the two heads of the gastroc, and then deep to that, you've got the big fleshy soleus muscle. Those two combine to form the Achilles tendon or the calcaneal tendon. If you say calcaneal tendon, nobody's going to know what the word you're talking about. So Achilles tendon. Not forming the Achilles tendon, there's the little plantaris muscle right there. I have no idea why you have that muscle. Anybody have it? Anybody? Why do you have that stupid little muscle?
I don't know, I had an exercise physics teacher one time say that they did experiments with rats and they cut their gastrocs and that they could still walk with the plantaris muscle. They saw like 40% growth rate in plantaris. And
That's BS.
I was like, the muscle's like this big, I don't think.
The muscle's only that big, and it's less. It's about the width of a pencil,
Yeah.
a number 2 pencil. You know, when I was a student in graduate school, there was my advisor, or the head of the course. He was this old Eastern North Carolina country guy that, you know, old-time anatomist. I had just finished PA school a couple of weeks before, so my lab partner and I, we took the palmaris longus tendon and muscle, and you see where this muscle goes from lateral to medial? We took the palmaris longus, and I sutured it in up here, and I sutured the tendon down here, so you couldn't see the sutures. And I hit the sutures, you'll learn how to do that later on. I hit the sutures, so it looked like there was a plantaris going either way. I said, Dr. Burden, can you come over here and take a look at this? And so he walked over there and he looked at it, and you know, Wes and I, we were, you know, like, and he always had his hand behind his back, and he would look down like that, and he got closer and closer. He got closer and closer. Wes and I got closer and closer, like that. And we were like right on top of this thing, and you know, kind of looking at him like, and each other like, he's not going to know what this is. He's not going to. All of a sudden, he just reached up there, grabbed that thing, and jerked it out. He said, "Palmaris longus." That's a true story. It scared the pee out of me. So don't do that today, because I know. So these, the Achilles tendon attaches to the superior aspect of the calcaneus bone in the foot. We'll go over in a minute. As does the plantaris tendon, but they're not. Plantaris tendon is not part of the Achilles. Now, another muscle that you're going to see back here is not part of the leg, it's actually part of the knee, is the popliteus. And I mentioned that the other day, so we'll want to make sure you see that in lab today. Popliteus, the flat muscle, but pretty large, pretty wide. Okay. So deep to the soleus, you'll find the nerves. The nerves are the nerve and artery. The artery is the posterior tibial. And the nerve is the tibial. It's the continuation of the sciatic. Well, actually, the common peroneal that gives rise to the deep and superficial, that's a continuation of the sciatic too, you know, right? Okay, but this is its continuation into the posterior leg. Now, there are 3 muscles that are in the deep layer. Those right here. The weird thing about these things is, in the cadaver lab, you're going to be able to easily identify the superficial muscles. These deep muscles, though, once you get up here onto the back of the calf, it's really hard to separate the muscle itself. You know, one of the 3 muscles. It's hard to separate them. You can find their tendons down here, but the muscles, they just look like they're all mixed up. And they are, but they know which part to contract to flex your big toe versus your other toes. Okay? As a matter of fact, though, if you stop and think about it, if you try to flex your big toe, the other ones go with it. Right? It's not like you can do this, you know, that doesn't happen. Huh? That's the wrist drop. Yeah. Anyway,
radio nerd.
so you'll see the muscles, they all look the same. You just can't pick out the flexor hallucis longus. And that's right, if you stop thinking about it, you can't do one toe over the next. I mean, maybe you can, but normal people can't. All right, but here's how you find which one goes where. Right here behind the malleolus. Now, the peroneus muscles go behind the lateral malleolus. The tendons of the three deep muscles go behind the medial malleolus. In this order: Tom, Dick, and Harry.
Good job, Tiana.
Tom is tibialis posterior, Dick is flexor digitorum longus, and would be the artery and the nerve, and Harry is the flexor hallucis longus. That's where you find them behind the medial malleolus. So in physical diagnosis, if I ever see you palpate the posterior tibialis pulse on the lateral side, I'm going to wrap you in the head because it's on the medial side. That's where the pulse is. I had a medical student, and they were going to remove a mole or something off my leg. My wife was sure it was cancer, it was a freaking mole. And they were doing the assessment, and she just got right there on my lateral malleolus, behind my lateral malleolus to palpate that pulse. And the whole time I'm thinking, you ain't even on the right side of your foot.
Did you say anything?
No, I didn't say anything. She was also the one that put, once she closed it, she put a 6-0 stitch in it. Remember I was telling you about the bigger the numbers, the littler it goes? 6-0 is about the length of a hair. So I had scrubs on that day. So I said, you know, appreciate it. And she did a punch biopsy. And remember, I think maybe she, did I tell you the story? She did a punch biopsy. What did I tell you to do with a punch biopsy? Take your fingers and do it like that. She didn't do it. She punched it. And there was a hole. A perfectly round hole. She put one 6-0 stitch in there and said, you're good to go. And I'm thinking, not really, but okay. I got up, walked back across campus, and I'm standing there teaching something, and I felt this water running down my leg. And I looked down, and I was bleeding out. The whole front of my scrub was just coated with blood. And it was, so
What was the look on your student's face? So I don't know. Like,
Yeah, why didn't anyone tell you?
No, we were working with cadavers. We were doing a workshop. It wasn't an anatomy lab, but we were doing a workshop. And I was standing next to the cadaver tank. And I said, what the heck is that? And I stepped back, and there was just blood was just pouring into my, I mean, not pouring, it was running down my leg and into my sock. And so I had to go find some, it was just, I guess I should have known when she started to palpate the posterior tibia on the lateral side of my foot. You probably need to go back to school. Nerves of the leg, here they are defined. So you've got, remember I said the other day, remarked the other day that, well, I'll bring it up later, sorry. On the plantar surface of the foot, I'll show you in a subsequent slide, but on the plantar surface of the foot, you have a medial and lateral plantar nerve that come from the tibial. So it's very easy. That's why when you're doing sensation to the plantar surface of the foot, it doesn't matter if you do medial or lateral. They all come from the same nerve up here, being the tibia. This is the one I wanted to show you. Remember the other day I said that there was the deep peroneal or the deep fibularis came? There it is right there. The superficial gets the rest of it, the deep gets that. All right. The arteries of the leg, the popliteal, now this is, we're looking at the posterior aspect. The popliteal artery is up there. Just as it gets past the knee and at the top of the interosseous membrane, that's when it's going to give off the anterior tibial. The anterior tibial, it goes down for a short way, and then it'll branch into the posterior tibial that'll go on the medial side, and in the peroneal artery that goes on the lateral side. It's the lateral compartment. The veins of the leg, if I have to say anything more about the veins of the leg, I'm going to puke. Small saphenous is what you're going to see here. Great saphenous. You do need to appreciate where they arise. Again, the great saphenous from the medial aspect, the dorsum of the foot going up the medial aspect, and then the small saphenous draining the popliteal area, the plantaris area, and going up the posterior part of the calf. Here are the ligaments on the lateral surface of the foot. There are 19 billion ligaments in the ankle and foot. Thankfully, you're not going to have to know many at all. However, I will point out, here's the lateral malleolus. Here's the calcaneus, the talus is here. The navicular bone is there. There's a little ligament right there. It's called the anterior talofibular ligament. That is the one that's most commonly stretched or torn when you roll your ankle or invert your ankle. The anterior talofibular ligament. If you'll notice the ligaments here on the lateral, they're just little bands. You got a posterior talofibular, you got like 4 little bands, but they're bands. They're not connected to each other. They're little thin bands. That's why it's so easy to roll, to injury your ankle. You're only dealing with these thin bands of ligament. Again, anterior talofibular, that's the one you need to remember there for your boards and for the exam. On the medial side, though, look at the medial side. It's not a band, it's the shape of a triangle, which is also the shape of a delta. That's why on the medial side, that ligament is called the deltoid ligament. I didn't make it up. Katie, that's just the way it is. The deltoid ligament. So over here, you have these thin bands. Over here, you've got this big, wide, fat. That's why it's almost impossible to have an eversion injury of your ankle because of how big and hardy that deltoid ligament is. Here is a sprained ligament. A sprained ankle, not a sprained ligament. I mean, it is a sprained ligament, but sprained ankle. You'll see ecchymosis around the area here, usually some swelling. If the ecchymosis goes above the malleolus, or if there's tenderness over the malleolus, you need to x-ray it. There are certain criteria for x-raying a sprained ankle. If you don't meet those criteria, the standard of care is that you don't x-ray the ankle. But like I told you before, it's difficult to assess a bone without an x-ray. So even though the guideline here would say do not get an x-ray, I typically do. Just to be on the cautious side.
So that one is a sprained deltoid ligament?
Not a deltoid ligament. Oh, yeah, this is the medial side. I think it's the medial side. Is it the medial side?
Yeah.
Okay. Yeah. Although that was showing a lateral movement. Okay. Now, there's a test called the drawer test where you put your hand behind the heel, as this illustration shows. Put your hand on the distal tibia, the fibula, and you pull the foot forward and backward to test the integrity of these calcaneonavicular and talofibular ligaments. All right. This particular type of fracture, you see the mechanism of injury right here, where it's a forced eversion like that? That'll pop off the, it'll fracture the distal bone segment here. This is called a Potts fracture. Potts fracture. This arrowhead right here, they're showing a congenital anomaly, so forget that side. That's the fracture over here. They've taken the malleolus and actually just popped it off. Very painful, usually going to require surgery to line it back up. Potts fracture. This is a dislocated ankle. Not much else to say here. You're going to have to get that back into place and then get them immobilized for quite some time. Understand that this, the mechanism here is, there's the tibia and fibula up there, so the talus is back here. So it's been pulled, it's a posterior dislocation. So you would grab that, pull down and towards you and up to try to pop it back into place. The bones of the foot and the ankle, they're easier to understand than the wrist. You have a talus, the calcaneus is your heel bone. On the medial side, you have a navicular. In front of the navicular, you have a medial, intermediate, and lateral cuneiform bone. And laterally, you have a cuboid. Those are the bones of the ankle and the proximal foot. They articulate with metatarsals 1 through 5. They articulate with the phalanges. You have the same number of phalanges in your toes that you do in your fingers. The great toe has 2, the rest of them have 3. One, two, three. Okay? You're going to be x-raying a lot of feet, so knowing which side the navicular is on and which side the cuboid bone is on, you might need to appreciate that. Okay? You have a medial and lateral arch to the foot. As you see here, the medial arch is much more exaggerated than the lateral arch. There's the lateral medial arch. An arch, you know what the state motto is for Pennsylvania?
What?
The state motto for Pennsylvania. What's on their license plate? There's a little emblem on the license plate. Where do you guys been living? I saw that we're 49th now in teenage pregnancy.
Hey.
Yeah, we went from 48 to 49. Arkansas is 50th.
Yeah, we did
That statistic.
There you go, Mary.
Overall health, we're 50th because they added Washington D.C. Mississippi is overall health. So we're, you guys don't know what the state motto what's that thing called? It's a bridge. What's that thing called?
The top.
No, it's not called the top rock.
Keystone?
This one. If you take that one out, the whole thing falls. It's the Keystone.
Oh.
Pennsylvania is the Keystone State.
Oh.
If you look on their license plate, they have a thing that says,
Oh, yeah.
Who's seen their license?
In case we're ever on job videos.
right? Who's,
She looked it up.
you know, we're okay. Oklahoma is okay. I don't know if are we still okay?
We're okay.
Okay.
What does that have to do with anything that you're talking about this?
Because the keystone of the medial arch is the head of the talus.
Okay, I was like,
Bring it back in.
bring. It's like, what are you talking about?
It all makes sense. It makes perfect sense. And there's a ligament right there. It's called the spring ligament. If you tear the spring ligament, it supports the keystone, the head of the talus. It falls, and you got flat feet. Right there. There's the head of the talus.
Why are there cows on there?
Huh?
Why are there cows?
They have flat feet.
They have flat feet.
No, because here's the spring ligament right there. Right there. Plantar calcaneonavicular ligament. It's called spring ligament. It supports. No, I'm going to tell you about the cow. It supports the head of the talus. If you break that, if that ligament, I've got a picture of some freaking flat feet in there somewhere.
Yeah,
So,
I would
wait,
say,
hang on. Rein it in, Macy. Okay.
Hey, Ashley.
This picture right here is important because you also have these two transverse lines in your foot. So you can take your foot, I need a foot because I can't do it to myself.
Don't mind. No, that's so stank.
You have these slippers on, can you throw a foot up here?
Sure.
slipper. I hate these. At least your socks
See,
are right
you
foot,
can
thank God.
take, you can take his foot and even though his ankle mortise is still, you can take his foot and rotate it along those tarsal lines, right? Correct? So that gives you, you don't even have to evert the foot or invert the foot, or invert or evert the ankle. He can evert and invert his foot. Well, that's good for you, bad for cows. Because in a cow, all of this is fused. They don't have these transverse lines. Meaning, they can't walk. See, if you have like if you're walking down a dirt path in a pasture, you know how the ruts are like this? You can change your foot to walk on the side of the rut. A cow can't do that. So they either walk in the middle or on the side, but never in the rut.
Oh, that's such a good picture. That's so cute.
Because they don't have a transverse joints in their foot.
It all makes sense.
Google me a picture of a cow in a rut.
I'm trying to get by one.
I'll find
You can't
one.
do it, Blair, you can't do it.
Cow in a row.
See, it all makes sense. You can go home and tell your mama what you learned in a cow. If you give it a choice between walking in a rut or walking in the middle, a cow will always walk in the middle. Because it doesn't have transverse lines. Makes sense? You guys go out and start. Did you find one?
No, wait, no.
You got some porn site on that?
That was just.
What?
Animal porn.
Animal porn? All right.
Okay, so, I have flat feet.
I'm getting to your flat feet here in a minute. Now,
Tell me, give
another thing I want to tell you about is here's the calcaneus right here. There's a protuberance off of the calcaneus. It sticks out medially that allows for this tendon, which is the hallucis longus, flexor hallucis longus tendon to go under it. That groove right there is called the sustentaculum tali.
What?
So that's the protuberance on the calcaneus that forms that groove for the hallucis, flexor hallucis longus tendon. I bet you probably ought to see one of those in a lab, one of those foot, bony feet, articulated feet. All right, That's what I'm talking about. Okay, so there are a lot of ligaments on the plantar surface of the foot. Once you remove the muscles, there's a long plantar ligament here, and then there's a short plantar ligament. The spring ligament, I can't see it from here, is right there, it should be right there. Calcaneum navicular. There's the spring ligament right there. Okay, I'll see if I can get a foot dissected down to the ligament level so you can see these. Here's the tendon, by the way, of the peroneus longus right here, coming from lateral, going all the way across the bottom of the foot to attach over on the medial side. It goes all the way across and is deep to the long plantar ligament. Any questions about that? All right. Here are some muscles, origins, and actions, and assertions, and neurovascular supply. These are the two brevis muscles here. You know, you don't need to spend any time. It's obvious. It's intuitive. Extensor digiti brevis. What do you think it's going to do? It's going to extend the digiti. All right. On the plantar surface of the foot, the plantar surface of the foot is really complicated. And the way it's taught is in 4 layers. 4 layers, from superficial to deep. And I don't think you really need to spend a lot of time with these layers. Clinically, the only relevance is when people step on things like nails and glass. There seems to be a lot of glass in our lakes, so people that are out there spending the entire weekend sitting in a mud lake, they tend to step on glass. A lot of lacerations. Thankfully, most of the lacerations are of the heel. And the heel is protected not only by the bone, but by really dense fat over it and really dense connective tissue over that. Now the sole of the foot is protected by a plantar fascia. And this fascia, this aponeurosis, is like the palmar aponeurosis. It can become inflamed. It's a condition called plantar fasciitis. You may have heard about it. I'll bring it up later on. It covers the sole of the foot, and you can see the nerve and arteries below it. You remove the plantar fascia, and the first muscle you run into is the flexor digitorum brevis. It arises from the calcaneus, goes to the toes, and like in the hand, the flexors of the hand, where the superficialis and profundus tendon split and it went up underneath it like that, you get the same kind of thing in the toe. This is superficial to the long tendon, the flexor digitorum longus. The more superficial brevis tendons will split and the longus will go through there. Just like we saw in the superficial and profundus of the flexors of the fingers. You have an abductor hallucis and an abductor digiti minimi. They form the muscle masses on either side of the foot, just like you have the muscle masses here in the palm. Deep to that layer, once you remove the digiti brevis, you'll run into the tendon of the longus. Off of the longus, you've got lumbricals, just like in the profundus tendon of the hand. You also have a muscle that attaches into the tendon of the longus, right here. It's called the quadratus plantae. It's right up underneath the digitorum brevis. Quadratus plantae. That's an exciting little muscle, because you've got this big tendon crossing across there, and this little guy is inserting into the back of it. Like, what is it going to do? it helps, it aids in your ability to flex your toes. Here's another image, the same thing. There's a quadratus plantate inserting into the back of the tendon. And you do have a flexor hallucis brevis and a flexor digiti minimi that go to form part of the thenar areas of the foot. I don't really care that you dissect these out, but it is kind of interesting to see these different layers here, at least in the mid part of the foot. And here is the summary of all of the actions there. Here's a summary of the action of all of them. Now, the nerves of the area, again, medial and lateral plantar, you definitely ought to take a look at these, be able to identify which one's which. You might see it with a little white tag sticking on it later on. I'm not saying for sure, but it might happen. You might want to make sure you get an appreciation for that. Here it is in illustration form. There's a little deep peroneus right there. That poor little deep peroneus coming out between the first and second toes. Here's the arterial supply. We've got the anterior tibial artery right here. Once it crosses the ankle mortise, it now changes its name, called the dorsalis pedis. Dorsalis pedis artery. So you're going to, right there, dorsalis pedis. Huh?
The medial what?
Ankle mortise.
No, once it crosses the ankle mortise, or the ankle joint. When it's on the surface, the dorsum of the foot, it's called the dorsalis pedis. So those are the two arteries that you're going to palpate. The posterior tibial and the dorsalis pedis. The dorsalis pedis continues across the foot as the arcuate artery that will give rise to metatarsal and digital branches. You don't need to worry about those branches. If you can find, you need to find the dorsalis pedis though. And here's the posterior tibial right there. You better know what that looks like, giving rise to the medial and lateral plantar arteries that accompany the nerves. Here are the veins for the 9,000th time. They have the same names. Clinical correlation, shin splints. Anybody ever had shin splints? What shin splints are is your poor exercise technique because you don't stretch. What they are micro tears in the connections of the anterior compartment muscles, most notably the tibialis anterior on the tibia, and on the tibia bone. So you're tearing the origin of the muscle off the bone. The only way to get rid of them is rest and a slow return to activity, but you need to start warming up and stretching before you resume your activity. A ruptured Achilles tendon, obviously, plantar flexion is going to be the issue. I did mention that you can still plantar flex to the peroneus muscles, but not as well. If somebody complains of pain after exercise, extreme acute sudden pain in the posterior leg, but they still have good plantar strength, don't overlook the possibility of a ruptured plantaris tendon. I've seen that a couple of times, and the only way you can diagnose that, because it's so small, is with an MRI. You have to do an MRI of the leg in order to identify that ruptured little tendon. Varicose veins are due to incompetent valves in the superficial veins of the legs. This is a pretty bad case of them here. because the valves don't keep the blood in, they backfill. We've talked about pitting edema. Here's a good example of what a DVT looks like. Somebody comes in complaining of pain and unilateral swelling of a leg. First thing on your list of actors should be a DVT, especially if they just drove up from Houston yesterday, especially if they're not anticoagulated, especially if they're older. Superficial thrombophlebitis, I mentioned, this can be really painful and irritating, responds pretty well to a buttload of steroids, anti-inflammatories, and pain relievers. It's not an infection, so you don't need to put them on antibiotics, although it does look red and angry. We've talked about this several times throughout the course, but the leg is where you're going to see it most, and that is compartment syndrome. When you have trauma, a snake bite, or some other reason why there's undue swelling of one of the compartments. Because you have those three compartments of the leg, they don't tend to give very, very much at all. And this is an example of where they opened it up and did a fasciotomy, opened up the intermuscular septum, and let that, you got to keep it open and let it heal over days. You see, they've got this string on these ties here. They'll just be pulling it back together as the swelling goes down. Snake bites, you know, Oklahoma's big on snake bites, and you actually see this a lot. Okay?
This may be a stupid question, but why do you have to open it all the way from the top to the bottom? Why can't you just do like a small incision and let the pressure out that way?
It won't come out. It's not like there's water pressure that's going to shoot out a hole. You have to open, it's the whole thing. So you have to open the whole thing up. You know, it's like there have been, years ago, when they drilled the well here in Oklahoma, there was so much pressure underneath there that when they struck oil, it would gush up. And you see the picture of the oil coming up like that? It doesn't do that anymore. There's been so many holes poked in the earth in Oklahoma that when you strike oil, you got to do something to bring it up. It has nothing to do with this. I just thought it was kind of an interesting. You can't just poke a hole in it and relieve it like air.
So then what is it then? Because I thought it was blood that got stuck in the, if it's not blood
No,
or
it's
air.
just extravascular swelling. If you look at the muscle, see, I don't know how to, if you took a syringe and had water in there with a needle, and you took a chicken leg and you stuck that in the muscle, and you injected the water in the muscle, the whole thing will swell. But it's not like you can turn it over and the water will pour out. It gets within the spaces, within the extracellular spaces. That's why you have to open the whole thing up. It's not like a particular area. Now, if it was a hematoma, a solid fluid-filled stuff, you could go in and size that. But compartment syndrome involves the whole compartment. Here are a couple of problems that you see quite often. This is a bunion. And bunion, what a bunion is called hallux varus. Valgus, not because it goes out. It goes out, valgus. Varus goes in, valgus goes out. Hallux valgus. These things are typical in older people, mostly older women. What's been attributed to it is wearing shoes that are too narrow, like high heels and stuff, growing up. One of the problems with this is because I said that you have two little seismoid bones under the ball of the great toe embedded in the tendon. These guys get shifted off of there, and it can become quite painful. The other thing is callus formation on the tops of the other toes, those are called corns for some reason. This guy right here, fracture of the fifth metatarsal. You see right here? I don't know why I have that in with this slide.
What did you say corn was?
The what?
Corn?
Corns, they're really nothing more than calluses on the tops of the toes. The toes, the four toes, they develop, they have a tendency as you age to develop a hammer-looking appearance. They're like that, hammer toes is what they're called when they're bent, when they're flexed up like that. So the tops of them have a tendency to wear on your shoes, and you develop these painful, irritating corns. There are Dr. Scholl's corn pads and bunion pads and all sorts of pads you can put on your feet. You should stop and look at all this stuff next time you're at a pharmacy. We talked about this the other day, valgus and varus, knock knee, bow leg, and there it is. This is not my foot, but for those that are wearing heels, this is not anatomically what you were built to do. So I thought that was pretty interesting.
It's cute.
I've never worn heels that high. Okay, so here's Macy's foot. It's a fallen medial arch. The thing is, you can look at it, if you go walking down the beach, this is what your normal footprint looks like. But a flat foot person, it's more of a, you see the whole surface of the plantar surface of the foot. Flat feet. Anybody here, you say you have flat feet?
Yeah.
Yeah, okay, so,
I do.
it doesn't really affect most people. If it does bother you, there are arch supports that you can get to put in your foot. Get to put in your shoe that will help support you. Here's a flat foot. It's also called pes planus.
That's actually my foot.
This is Macy's flat foot. Rather puffy, I might add. Here is fungus under, yes, Blair?
Is it true that like the arch of your foot, depending on if it's like flat or not, it correlates with like lower back pain and stuff? Is there any correlation?
I don't really think so. Her question is, does flat feet correlate with low back pain? I've never seen that correlation written anywhere.
Wearing heels does give you back pain, don't lie.
It does.
You should know better.
This is onychomycosis, fungal infection of the nails. It takes 1 year to grow a big toenail from the eponychium, which is what the skin is called here, eponychium. Because it takes 1 year to grow a nail all the way out, a great toenail. So if you're getting ready to remove a great toenail, you need to advise them it's going to take a while before this grows back. Yellowish, thickened, they break easily, difficult to get rid of. And most of the time, if you get rid of it, it's going to come right back anyway. This is club feet, not club feet, but club feet. Most of the time, this type of contortion can be corrected over time. You can splint it, you can not do anything. Rarely does it require surgical correction. This little thing right here, this is one of those, if you're on Jeopardy deals. There's a painful little neuroma that can develop between your second and third, or third and fourth toes. It's a neuroma. It's like a ganglion cyst, is what it is. But it's down here on the foot, and it's very painful. It can be very painful. It's called a Morton's neuroma. And you see, in order to get, you have to surgically excise